Hi everyone, this is Holly. I'm actually a wound specialist out in the New England area, and I look forward to being able to teach you guys a little bit about our clinical foam dressing application. The first one that we're actually going to start with will be a basic application, and then we've added on a portion that will cover a little bit about bridging. So let's get started. And again, if you have any questions, just go over to the chat line, and what I'll do is if it's something I can answer right away, I will. If not, I'll just wait till the end and try to answer all the questions. Okay. All right, so our UNI negative pressure foam dressing kits, we made them very simple, and they come with the black foam, the dome pad tubing, and the transparent drape. And for the most part, with the transparent drape, many times you'll have enough if you want to actually border your wound and protect, and you'll be able to, like I said, go around and actually protect your entire peri wound with the extra transparent drape. If it's a larger wound, you may need to bring in a little extra bit of transparent drape. But usually the supplies needed would be, bring in your gloves, your normal saline, your sterile gauze, and that's really for just drying around the edges, a pair of scissors, and your protective barrier wipes, which is your skin prep. I will talk a little bit about scissors. I do believe it's really smart to invest in a good pair of, believe it or not, sewing scissors. Our nursing scissors do not always work very well, and I found by actually making an investment in buying a really good pair of scissors, I'm able to cut the foam much easier. Okay, so every time we start and we look at our wounds, we're going to do a full assessment on the wound to determine if negative pressure is even appropriate. It is appropriate for many wounds, but of course it is not appropriate for all of them, and we can talk a little bit about that later. I will also mention that for this dressing application, where this wound butt has, of course, a coccyx wound, and sometimes people would bridge. And there are reasons you might not decide to bridge on this wound. If a patient's laying side to side, you may actually decide to put the dome here. Otherwise, later we'll talk about bridging to the side of the patient. Once you've assessed that the wound is actually appropriate, you, of course, would be doing your wound measurements at least weekly per your facility protocol. And then usually what I want to do is I want to clean the whole area, and then I want to skin prep. I want to protect that fragile area as much as I possibly can. I want to make sure that if I'm changing the dressing, that I'm irrigating very, very well. You will see that with the black foam or any type of dressing that we use, particles can get left into the wound, especially if we have some undermining areas or some tunneling. So we want to make sure we're really irrigating the wound well. Now, after we apply our skin prep or our protective barrier, whatever your facility uses, as I mentioned, what I like to do is I like to border around my wound. And that's done as, again, just a secondary protection for some reason. If there is a leak during the night and somebody doesn't catch it right away, that we're not going to start creating a bigger wound by macerating the wound edges. And then we'll move here. Okay, so now we're going to open the Unifoam kit once everything's done. And we're going to turn around, and we're always going to cut our foam away from our area. So we're going to cut over here. We're going to dust it off to make sure that no particles are going to go into our wound. Now with the black foam, I'm not telling you have to use this, but some people will put another protective layer down, such as something like an Adaptec. If we see bone, and in here we are actually seeing bone, that would definitely need something to protect it. So you can use our white foam, or you can use something like an Adaptec to make sure that nothing's going to stick and adhere to the wound bed, which always is definitely a positive. So you're going to cut the foam to the size and the shape of the wound dimensions. And sometimes I say filleted. You may have to actually fillet the wound down if you have a very shallow wound, because you don't want a big thick piece of foam compressing down and actually causing pressure on the wound bed. So sometimes you may cut it here, but you may also fillet it across. The dressing size you are going to put in is going to be slightly larger than the actual wound, and I mean slightly. It can come up over the wound bed a little bit in depth, maybe about a few millimeters above. As far as the size, we're pretty much going true to size this way. Okay, so we're already here. I am going to return to the last one just so you can see the open area. We do have some undermining right here, and that's when you will want to use our white foam. The white foam has greater tensile strength, so it is not as, it won't fragment as much. Our black foam actually doesn't very much either, but I just want you to know that anytime you're doing a tunnel or you're doing undermining, you would be using our white foam. You would place it in so it goes into the undermining, but you would also leave a pretty good tail so that it's always seen when you're removing the dressing. Okay, so here we've actually placed our black foam in. Everything's nice. We have a white foam underneath, taking care of all our undermining or our tunneling. And again, it's very important that we never force anything because we don't want to cause further damage. Okay, now as far as we get here, you'll see that our drape, I think our drape is extremely nice because it's very clear 1, 2, 3 dressing. And for all nurses that are on here, we know how difficult transparent drape is to actually work with. This has a pre-cut hole. Ours don't come with pre-cut holes anymore because we found that honestly, a lot of times the nurses are going to cut away a lot of this drape. So it's better that if you cut away, you want this to be in the center. So we just decided that it wasn't the best situation to have the hole, and that the nurses literally can fold the drape in half, cut a hole, and unfold it and be able to place it right over here. So we would actually trim this down to size so we don't cover too much skin. The other thing we would do is we'd probably put a slit right here so that that can fold down onto the buttocks, and it will actually make a nice seal. You can also, if you're covering something like right here, where you have a little bit of an indentation, you can cover it with something like a duoderm or something like that, and only a thin duoderm. And again, that is all based on if the patient's skin integrity can take that. So after we size it and we have cut the hole, okay, we're going to place it down, make sure it's going to fit, and then we're going to begin our peeling. So of course we're going to peel our first tab first, and then we're going to place it down over with the hole centered. Here you don't have to, you're not going to be tugging, you're not going to be pulling, you're just placing it and lightly pressing it down around the area. Very, very, very lightly. You don't need to tug or anything like that. Then we're going to peel off tab 2, which is sort of underneath. We're going to peel those 2 tabs off. Again, gently pressing and working our edges of the drape so that it's smooth. And then over here, you can see right here, this is on. We've got our slit right here, so everything fits well. And you're just going to, at this point, look for the curves. You're going to make sure that everything is on, and then you're going to peel your layer 3 off. So once we've actually peeled our layer 3 and we have it all secured, then we're going to get our dome out. The dome has an adhesive layer that is just peeled off right here. And then we're going to be putting it on so that it's going to fit right over the hole. Now, when you do this, just think of where your tubing is going to come out and which way is the best way to position. Okay. All right, now you're going to properly align everything. We have 2 blue tabs now that need to be pulled off. in the top, there will actually be that secondary layer on this transparent as well. And if you look carefully, there is little zigzags, so you're able to get your finger in there and just sort of peel them up very, very easily. If the dome is not aligned correctly, there would be a problem. So you just want to make sure that your holes are aligned and matched up. Other than that, it really is simple, 1, 2, 3. Okay, so now you're going to always check. You're going to go around again, lightly, never pressing on the wound, but just lightly making sure that everything is adhered at this point. And after that, we've already peeled the back lining. I got a little ahead of myself there. Sorry about that. We've taken the blue tabs off and we patted everything down. Now it's sort of important to anchor our tubing. Now normally this tubing will probably come out this way, but it's important to anchor it. Some people will use a Foley catheter anchor. Otherwise, you really can just use either a piece of Hypafix tape, the pink tape, paper tape if that works for you, but we want that adhered down. And sometimes I'll put a little piece right here, because what I don't want is my tubing to start to go straight up here as it's pulled and start to pull up my dome. So the anchoring, what I have seen nurses do is they put a whole piece of transparent over this whole thing, and I don't advise that, because this is an air permeable system and that is actually how it works. So you want the air permeability here. So we don't want to cover the whole entire thing. We just want maybe a few pieces to anchor. Now we're able to connect our tubing. You may have an adapter that you need to put onto the tubing, and that will depend on the actual device that you are using. But once you put the adapter on, what's really nice is our system has almost like a lure lock type system, which makes a nice tight grip. It also makes it very easy to open and close and dislodge everything. So an adapter is only required depending on the pump that you are using. So Joey can talk more about those adapters. Okay. Now you're ready to go. So now at this point, you're going to put your to your canister connector. So connect your tubing to your canister connector, and then you're going to turn your pump on. Now, of course, it's totally dependent on doctor's orders. The usual is 125 millimeters of mercury. Sometimes you will see a doctor go down to 80. Some will go down to 100. And that is something, again, that is 100% physician related. Once that is done, what I like to do, if I'm able to on my pump, I don't like to start it at 125. I actually like to decrease to maybe start it at 80. Allow this to start to compress and then build it up to 125. And the only reason I say that is when a patient is maybe on Coumadin, maybe on heparin, may have a lot of vascularity to that area, not to mention pain. I like to take it a little bit slower so I cause less pain. So I just make a habit of decreasing down a little and then starting. Is it totally necessary? No. If the patient has had the wound a while and is very accustomed to this, and the patient has no bleeding issues, then again, you would determine that. Otherwise, I find that, again, it has definitely decreased pain levels during applications. Everything is so gentle on this system that really you don't see a lot of pain. But a patient who has maybe been newly debrided, things like that, there's always the question of making it a little bit gentler at the startup. And we know that bridging and Y-porting may be necessary for some of the wounds. So we will sort of evaluate that as to whether we would do a Y-port or a bridge. But again, I want to look at this right now and just talk for a few seconds about the fact of a lot of people say, well, you have this on the coccyx, you have to bridge. I think that is totally determined on how the patient positions. If a patient truly is a side-to-side patient, and I do find that keeping the dome here is appropriate, because my want is to keep the patient completely off this area anyway, and I'm doing side to side. I'm putting a pillow so that I have different side to side elevations. But if I did bridge over, I wouldn't want to bridge onto a hip and then try to go side to side. So I would have to bridge almost all the way over towards the front side of their hip area. But just keep in mind that you may not always have to bridge if a patient is compliant to do side to side. And again, before you actually turn on the negative pressure, make sure all your tubing clamps and everything is open, the canister is on correctly. We'll see a lot of times that the canister isn't completely connected. Now we're going to turn on the negative pressure system. And once it's turned on, you should see that collapse. And this area should become almost raisin-like. You'll see basically a shrink wrap. All the air will be taken out of the wound. If you've done a really good job of irrigating, you'll probably start to see some of the saline removing from the actual wound. And you'll get this compressed look. And the compressed look means there's a proper seal. And then you're going to check, once you start at your initial dressing change and you put it on for the first time, I don't like to, at that point, maybe have it go 72 hours. I might actually take a peek at it in 24 to 48 hours, again, depending on if the patient has any other issues. Again, maybe a fresh depleted patient or a patient that has a high infection. I may want to see that wound sooner than in 72 hours. But the normal is it's a 72-hour dressing change. Many facilities will set that up on a Monday, Wednesday, Friday schedule. But once they initiate, it's definitely something that in my care plan, that dressing is being checked every shift. And again, sometimes more often depending on what the status of the patient is. You're going to start watching for any adverse reactions. If you were to start seeing dark blood that's filling the canister, of course, that could mean a potential bleed out, so that would be stopped. Sometimes you'll just see serous ang blood going through, and that's pretty normal. That in the beginning you may see a little bit of that. We will jump to the bridging side, and then we'll talk a little bit about bridging. So we're going to sort of jump back for a second so that you can see the difference when you actually bridge. Let's see. Hold on just one second. Okay. All right, so I'm just going to go back so you can, okay. So again, if we actually are bridging and this is a wound and we've decided to bring the bridge across here, we're going to still do the same things. We're going to irrigate. We're going to make sure we use the white foam. We're going to protect that bone. We're going to skin prep. You can always, again, go over that with a protective layer of a transparent or some type of protected layer dressing. Then we're going to create our bridge, and we're going to decide where our bridge is going to go, and we're going to cut it to the length right here, to the length that we need to bridge to. So for here, again, we're working with this small thing because there wasn't too many places we could bridge to, so we brought it down here. So you are going to cut a piece of transparent drape wider than what you would cut the foam bridge. So you want it wide enough so the edges of the black foam do not touch our good skin. So we're definitely protecting our skin integrity here. Once this is cut, you're going to peel the strip and you are going to place along the edge of the wound and place down to where we're going to bridge. So now we're bridging for demonstration purposes to this particular wound or this site for the dome. So here we have this. We're going to peel off that layer, and then we're going to treat our first wound. We're going to cut our foam just as we did for our first wound. And then we're going to make sure that we take care of our first wound. And as you can see, again, it goes right up to that edge. I want to make sure every part of that wound right here is completely protected, because literally we're going to be pulling some of the wound exudate out and across the bridge. So that's why we would never want to not have the bridge there, because it's protecting our skin. Okay, then what we're going to do, this is a bridge to a second wound. Sometimes you're bridging to a second wound, sometimes you're bridging to the side of the patient. So for this one, we're actually bridging to a second wound. So now you're going to actually cut your black foam to fit over this wound. Okay, so we're able to treat two wounds at the same time. All right, so now we have both of our wounds have the black foam, and then we're going to cut our bridge slightly smaller. It should be at least maybe 1.5 inches wide. So therefore this part of your bridge for your transparent should be at least 2.5 to 3 inches wide. And as you can see, we are able to lay our bridge down. Now sometimes it is easier if we fillet our bridge so it's not quite as thick. Cut this and then just fillet it down so that it's a little bit thinner. Sometimes that works better and the drainage is able to move better, not to mention it sometimes is more comfortable for the patient. So it has to, the black bridge right here, your black foam bridge has to touch your first dressing. It has to overlap onto your second dressing. Okay, so we need to make sure that those two things are connecting and touching in order for negative pressure to be able to pull from one end to the other. All right, now you're going to cut the drape and you're going to properly seal the small wound and the larger wound. So for example, this, you're going to cut and you're going to cover this whole entire area. So again, we're going to peel the first tab, sticky side down on the patient's skin, and we're going this way. And of course, again, we realized that this wouldn't be appropriate. We'd probably have to carve this out if it was a real patient so that we're not blocking any areas. And we're going to cover them at the same time. And we're going to cut our hole, okay? So we're going to have our hole now cut down here. And you'll see what will happen. So we're peeling off number 1, number 2, and we're getting over here, and here comes number 3 off. Okay, so now we have the entire thing sealed, and let's see, I just want to make sure. See, we did the bridging to 2 wounds, so I will show you 2 different ways. In this particular one, we cut the hole up here, and the reason we did that is we're treating our largest wound with the dome. So in this particular sample, we're treating a secondary wound, but we're going to have the hole cut up on the primary wound. And usually the larger or the more contaminated type of wound is where I will place the dome. So here we place the dome here, and then that's where our hole is cut. The dome will meet up the holes. And we place it down. We take our layer off, the secondary piece of our top layer of our transparent off, and then pull off the 2 tabs. And now you're treating both of the wounds. If you were bridging to the side of the patient, your dome would have been moved down to here. That would be the only difference. We would have put a hole down here, and we would have moved it down. And what I will add, and you guys can ask questions because there's so many tricks to everything. If we were bridging technically to the side of the patient here, so that the patient, the dome is no longer here and is here, we would have needed a larger piece of black foam here to be able to fit the dome onto. So we wouldn't be able to take that dome and put that right there on that foam. It's too small. So we would make this dome maybe a square or a circle, and just a little bit bigger, and the dome would move down here. Now, when you are treating 2 wounds, I've had nurses ask, do I have to increase my pressure? No. Each wound is getting 125 millimeters of mercury, and all it is doing is this wound, because all our foam touches, the drainage from here is moving down here to our larger wound and then out of the system through our tube, as well as the primary wound is also pulling drainage. So again, that's so important that everything touches, so there's no break in the flow of the exudate up and then out. So you're not going to, and you would definitely have a problem if the bridge was too narrow. That's it as far as the dressings go. I hope I didn't move too fast. If anybody has any questions and they want to ask any questions, just put on a little thing on the chat line, and I will try to answer those for you. I'll give a couple minutes like I said, if anybody has any further questions, they can, and if anybody has anything specific that they need to talk to me about, they can also do that. You can put your phone number in, and I'll be happy to call you.
And guys, all this information that you guys listened to today or watched today will be posted on our YouTube channel. If you just go to search or YouTube us, it's Equinox O2 Medical is our channel name. And we will also post this information on our website as soon as we're finished here, probably tomorrow or Monday. It should be on our website under how-to videos or under webinar. You'll see a copy of this webinar that we have on our website. It's www.equinoxo2.com. And guys, we're gonna give a couple more minutes, maybe 2 more minutes. If we don't receive any questions, we will end the webinar. And we want to say thank you to everyone who joined us today, and keep an eye out on your email because we've been getting a lot more requests for this type of webinars in regards to dressing changes. And if you can send us suggestions on what else you would like to see on a webinar, techniques, dressing techniques, finding the proper seal, just send us an info and we'll put something together for you guys. And if you want to set up a different webinar just for your particular group, we can do that as well. Just send us an email. I'll type in my email on the bottom of the chat line so you guys can see it, and you can shoot me an email there.